Welcome this afternoon to all of our participants. I would like to start by introducing our RRTC to you, the IDEAL RRTC, which stands for Investigating Disability Factors and Promoting Environmental Access for Healthy Living, RRTC. The overarching goal of the IDEAL RRTC is to promote the healthy aging of adults with long-term physical impairments and disabilities. We are achieving this by identifying factors at the intersection of the person and environment that impede or support positive health and function outcomes. And we are also creating solutions that improve the fit between supporting positive health and function outcomes. Our IDEAL RRTC contributes to the understanding of successful aging with disability by investigating the interplay between individual factors and social and environmental barriers and facilitators as they hinder or promote healthy aging and community participation. We conduct various research activities to promote the healthy aging of adults with long-term physical disabilities, and this webinar highlights one of our key research studies. Elham Mahmoudi, who will be our presenter and is the primary researcher on this project, joined the Department of Family Medicine at the University of Michigan as an assistant professor in 2017. She earned her PhD from Wayne State University here in Michigan in economics in 2012 and subsequently finished her postdoc research at the University of Michigan. Dr. Mahmoudi is a health economist with expertise in large data analysis and methodologies. Her research interests include evaluating healthcare policies, reducing disparities in access to quality healthcare, and optimizing care management for patients with multiple chronic conditions and those with Alzheimer's disease and related dementia. I'd like to provide a brief summary of the webinar, and then I'll pass the baton to Elham. This webinar is focused on research that Elham has been conducting on adults with pediatric-onset cerebral palsy and spina bifida, or acquired disabilities, including spinal cord injury and multiple sclerosis. These individuals are more likely than those without disability to develop medical complications. Prior to this research, little has been known about the potentially preventable hospitalizations among adults with disabilities. These hospitalizations are preventable if patients have timely access to care. The objective of this study was to examine the potential risk and protective factors for preventable hospitalizations, comparing adults with these disabilities to people without. Our results indicate that adults with disabilities are at greater odds for preventable hospitalizations compared to people without disabilities. Our findings include that the use of preventive services such as annual wellness visits had substantial protective association against potentially preventable hospitalizations. And with that, I would like to introduce Elham.
Thank you so much, Robin, for the introduction. Without further ado, let me share my screen and start the presentation. Do you see the screen?
We do see your screen. It looks great.
All right, great. Thank you. So let me start. I'm Elham. Good afternoon. It's a pleasure to be here, though I would have preferred to have it face-to-face, but here we go. As an acknowledgement, as Robin mentioned, this research has been funded by NIDLR, National Institute on Disability, Independent Living and Rehabilitation Research. I would like to very first acknowledge my co-investigators, Dr. Mead, Clark, and Rantal, were the PI for the project. Mark and I were the co-director for this section of the project, and I would like to thank soon to be Dr. Khan, Kamdar, and Lean for their extraordinary work on this specific project. I'm condensing 3 manuscripts together for these specific presentations, and these 3 individuals, it's a teamwork. I'm just presenting our teamwork basically today. I have no conflicts of interest to disclose except for the fact that I am an economist. I have an extremely dry sense of humor, so I ask for your forgiveness for no animation, no cool graphs or figures here, bunch of numbers, but the topic is interesting, I believe. So the agenda for our today's talk, I will go very briefly introducing claims data because we use claims data for this analysis, for this set of studies. And then I will go briefly over the backgrounds of these 3 conditions that we cover: study aims, data and method, and results and policy implications. I have to go very fast, so if you have questions, please put them in the chat or email me directly. My email was at the very beginning. I believe you will have, you already got my email address. If you have any question that you didn't have time to ask during the session, feel free to email me at any time. So to briefly cover what are administrative claims data. Basically, they are not developed. Administrative claims data do not have not been created for research purposes. They are for billable services throughout healthcare system. And there are 3 parties involved in each claim record. First, patient will go see the physician or hospital, any type of provider to receive healthcare needs. The provider needs to be reimbursed for the services that is provided. So that provider, to get reimbursed, will contact the payer or insurance company. This whole transaction will be recorded in the claims data, and that's basically the content of it. So claims data cover all billable or payable healthcare encounters, whether it's the office visit or inpatient hospitalization, ambulance services, or prescription drugs. Anything billable through your health insurance will be recorded in administrative claims data. To provide some examples, CMS is a claim-based database that basically administers Medicare and Medicaid data. Optum Insight and Truven Analytics are examples of insurance, private insurance claims data. Just to give you an overview, and we have done this before, there's some similarities and differences between them. Medicare claims data specifically cover fee-for-services, and they cover services for adults 65 and older and people with disabilities. Optum Insight and Truven Market Scan are private insurance. They do cover individuals of all ages. So those who are 65 and older are those that are covered through Medicare managed care, not fee-for-service. As a social scientist, I'm very much interested in Medicare claims data just because it gives me more options to merge claims data that do not include social determinants of health or any type of socioeconomic variables with claims data. Medicare and Medicaid claims data provide 9-digit zip code of the primary residence of the enrollees, so we can merge them with track level or block level or even zip code level data from various sources and actually merge those data with our claims data. Those option is much limited in Optum Insight or through one market scan, because Optum Insight only if we use the zip code level provide the 5-digit zip code, and there are some restrictions on how to merge the data with other data sets, and market scan doesn't provide it at all. It's at the state level. So to summarize, commercial insurance, or that's what we are using in this set of studies, we use Optum Insight, include basically inpatient, outpatient prescription drugs. You can identify if the provider was primary physician or a specialist, the place that the service occurs, is it outpatient or inpatient, and prescription drugs. If you want to think of claims data, you can think of any type of rational database. That's basically a definition of claims data. It contains various tables that are linked together based on unique patient ID or enrollee's ID. Each claims data contain a file called enrollment. In Medicare files, for example, they call it master beneficiary summary file. You will find some demographic information about the enrollees, such as age, sex, date of enrollment, if it the beginning date, and end date if it's been ended. And there are other examples that we have medical claims data that include basically all transactions that happen. Again, inpatient or outpatients. To define those transactions, we need to talk the language that has been talked in medical claims, meaning either using ICD-9 or ICD-10 codes to define the diagnosis, or using CPT codes to define the procedure codes, either CPT or HCPCS codes, which are American Medical Association's CPT codes. Using those, we can define our cohorts or procedures that they have been performed. We can also, as I mentioned, define the facility, either it's inpatient or outpatient, and provider type, prescription drugs. Lab result I've never used in any claims data, and based on my understanding, they are not reliable in Optum either. We have not used them in this study. So this is again an example. We provided these previously in our previous ICPR presentations. Just to give you an example, as you see, there are patient IDs. We have beginning date and end date, gender or sex, and other demographic information here. We do have diagnostic and procedure codes to identify our patient cohort and services that they have performed. Also, one thing that's of importance using claims data, and that's their positive point, is either charges or costs. We do have charges, but I do have to warn you that charges are not equal to cost. We usually measure cost by the amount that was reimbursed. They're both available in claims data. So we have the total charges. We can also measure out-of-pocket costs by summing up the copay and deductible. And we do have the standardized cost, that is the cost that was reimbursed based on the CPT code that is provided for each services. And usually there are several lines for each service that's provided. So if you're looking at a specific procedure, you can sum up those specific service line to come up with the total reimbursement amount. Again, in this study, we did not look at cost. What we measured was potentially preventable hospitalizations, which I will explain briefly later. So that was the summary. That was the first part of the talk, summary about the claims data and how we can use it for health services research purposes. Now, for this specific study, we were looking at 3 sets of disability: congenital or pediatric-onset disabilities and acquired disabilities. So the first thing that we did, based on what I described, we used the ICD-9 codes to define our patient cohort. We looked at individuals 18 and older. then we made sure that they have at least, because that's a longitudinal analysis, we made sure that they have at least 4 years of continuous enrollment so we can measure the outcome variables that we were interested. For pediatric onset conditions, cerebral palsy and spina bifida, the index date is actually fictitious date because these conditions happen at the time of birth. So we are not measuring incidence, it's the prevalence that we notice in the claims data because we're looking at adults with these conditions. But we define our cohort, we set our index based on the first date of diagnosis. We use 1 year look back period to measure all chronic conditions to risk adjust this patient cohort when we are comparing them with our control group. And for congenital conditions, we make sure we have at least 3 years of follow-up, continuous follow-up to measure our outcome variables. Similarly, we have the same thing for acquired condition, people with diagnosis of multiple sclerosis and traumatic spinal cord injury. In that case, the index event is the actual one based on the first diagnosis of the condition throughout the enrollment period. Again, we use a 1 year look back period to define chronic conditions and 4 years of follow-up to measure the outcome variables over time. So just a brief background, what are these conditions? And again, here I'm an imposter, I'm an economist, not a physician, but just to give you an overview about these conditions, cerebral palsy and spina bifida are pediatric onset disorders or condition known to cause an array of permanent movement disorders. The incident rates is about 2.5 per 1,000 for CP and 1 in 3,000 for spina bifida. And the most important things is life expectancy of adults with these conditions have increased tremendously over the last 2 decades. Therefore, the research that has been more focused for pediatric, among the pediatric cohorts needs to move up to adult cohort, because these are the people who usually we don't have health centers for them. The care is not coordinated, and that's why it's important to include them in this study. Multiple sclerosis is a chronic inflammatory disease of the central nervous system, typically diagnosed between the ages of 20 and 40, and it's a neuroinflammatory condition. And it's permanent, it's a chronic condition, which gets worse over time. Traumatic spinal cord injury, mostly caused by motor vehicle accidents, falls, or act of violence, and usually cause permanent disability. Now, working with claims data again, the main important thing is to define your cohort accurately and completely. So I remember when we were conducting this analysis, we spent months to make sure our ICD-9 codes, in this case, we use ICD-9 because we wanted to make sure we have 4 years of follow-up for this patient cohort. So we didn't need to use ICD-10 codes, which were introduced in October of 2015. Even now, when I go back, there are things that I wish we were included that we didn't include at the time. So spend as much time needed to define your cohort using ICD codes for diagnosis. Potentially preventable hospitalization. I want to spend a few minutes to explain what they are. They're based on prevention quality indicators, which were developed by the Agency for Healthcare Research and Quality. Why do we call them quality indicators? Because these conditions are conditions that could have been, the hospitalization for them could have been preventable if patient has sufficient access to care. They are used as quality measure, basically, to evaluate quality of primary care or physician services. For instance, a very good example would be urinary tract infection. It's something that easily can be addressed through office visit. Patients do not need to get hospitalized. It's not efficient. They're using resources that are not needed. If patient has timely access to a physician. That's why they are very important. They measure every year. ARC, or Agency for Healthcare Research and Quality, provide a report every year and track these services over time. So these are 10 PQIs. I would mention them. Again, as I mentioned, going back to my explanation for claims data, for each of these, we have a set of ICD-9 or 10 codes that identify hospitalizations for these conditions. We looked at all 10 PQIs for our patient population. For each of those, here is just an example for the first one, PQI number 1, which covers diabetes short-term complications. I provided ICD-9 and 10 code here in this table. And there's a set of exclusion criteria, which is important. And for that, I just need to thank Dr. Khan and Pauline, because it's extremely hard. There are 10 conditions. You have to check your claims data to ensure that your inclusion or exclusion criteria for that one binary variable that you create to define PQI number 1 is accurate. For those of you who are interested, a complete list is provided. I have it in the footnote in the ARC website, and you can access those. For instance, in this case, people, though, it could have been in our cohort actually, those who are pregnant should be excluded. This is just an example. So this is again another example. All of these, all manuscripts have been submitted. When they came, they're in the supplement file. But again, for those of you who are interested, these information are provided in our website. There are additional exclusion criteria with the specific codes that have been mentioned for each of these 10 PQIs, which we followed. So why is it important? The rationale for conducting this study, why we are interested in potentially preventable hospitalization among people with disability. We know through our own work and work of others that prevalence and incident rates of comorbid conditions, cardiometabolic, psychological, musculoskeletal, and other conditions are substantially higher among adults with CP or Spina Bifida, MS, or those with traumatic spinal cord injury compared to adults without those disabilities. And compared with general population in general, because most of these people lack regular mobility, access to care is much harder for them. They have more complex health needs and therefore are more prone to adverse health events. On the other hand, we know that healthcare system in general is expensive. It's right now in the United States is about 17.7% of our GDP goes to healthcare system. Hospitalizations is an expensive use of healthcare system and should be avoided if there are other mechanisms to address the condition. Potentially preventable hospitalization is among one of them. So the rationale for this study came from that. That's why it's important how we can make the healthcare system more efficient, value added for this patient cohort that we know are at higher risk. So the main objective of this study was to determine, or was to examine basically the risk of potentially preventable hospitalization for this group of adults compared to adults without disability. And what we are after, who cares basically about that, is how we can address modifiable factors. If we know that certain PQIs, certain potentially preventable hospitalizations are higher among this patient cohort, maybe we can change the guidelines when they can see the doctors, or use preventative services to address these adverse health events, I would call it, or potentially preventable hospitalizations among this patient cohort. So this was the second part of the talk. And now I will start. Let me just check the time to make sure I am on time. The second part of the third part of the actually talk, I'm delving into data and method. Again, as I said, there are 3 papers. So I will go over data and method, which was similar for all 3 studies. And then I would go through the results and policy implication for all of them. So for this study, we used Optum Insight claims data for 2007 to 2017. Our patient population included adults 18 and older with continuous enrollment for at least 4 years or over, with diagnosis of CP or spina bifida, MS, and traumatic spinal cord injury at any time during the study period. Outcome of interest was potentially preventable hospitalization. We had one composite measure of any PQI, any PPH at any time during the 4-year follow-up period. We also looked at each specific PQI because that's of an interest, which one is more common among this patient cohort. Our independent variables included demographics including age, sex, race, and ethnicity, because we use that view of Optum Insight. As I mentioned, there are 3 views in Optum Insight based on SES, zip code, and date of death. We used SES specifically to have access to race and ethnicity, and US Census Division data. We also, using the SES view, we also had access to net worth or net income and educational attainment of each enrollees. For health variables, we use that 1-year look back period that I explained earlier to identify diagnosis of any cardiometabolic, psychological, and musculoskeletal condition. We also included Elix-Hauser Comorbidity Index, which was also introduced by ARC. And there's a website how to estimate and calculate Elix-Hauser Comorbidity Index. What else? We also used the diagnosis code that I explained for, oh no, that I did not explain. One thing that was of importance in this paper, in this study, was to see if use of preventative services, preventative services, such as annual wellness visit, diabetes screening, cholesterol screening, would have any association to reduce the risk of potentially preventable hospitalization. So we use those time varying variables in our model to see their interaction with disability and their effects on potentially preventable hospitalization over the 4-year time period. So these are our sample sizes for each group, about 10,000 for CP spina bifida, 5,000 for spinal cord injury, and 6,000 for MS. We did match our cases with controls, those without disability, based on age and sex, because as based on previous studies of our own and work of others, we know that as people age, their health needs increase, risk for PPH increases. Also, there are some studies showing that it's more common among females compared with males. So to get those out of the way, to make sure we are comparing apples with apples, we matched based on age and sex, but purposely let other chronic conditions, health conditions play their role, and see their effects in the model for increasing or decreasing the risk for PPH. Because it was a longitudinal study, we used a multivariable generalized linear model we applied the binomial distribution and log-link function to address the repeated measure over time, because we followed each patient for years. To measure these things, we use generalized estimating equation. And for the full PQI measure, any PQI, we used interaction terms. Our main exposure variable was the disability, either CP or spina bifida, MS or TSCI, with all other important variables in the model, such as sex, race, ethnicity, use of preventative services, and so on. We couldn't do that in our models for each PQI because of the small sample size. And at the end, the odds ratio that you see is the result of adjusted marginal odds ratio based on our regression models. I just want to briefly explain here, if you're interested, when you run a nonlinear model and you have interaction terms in your model, you cannot just use the coefficient of or odds ratio of the regression model, because it's the standard errors and therefore significance value is not correctly calculated. If you're interested on this topic, therefore you have to use the marginal outcome or adjusted predicted outcome for that variable. If you're interested, look up the work that has been done by Ed Norton, search for Ed Norton and nonlinear models. So to just briefly explain, we use SAS for our calculations. So we used LS means. If you're using Stata, you can use a marginal command in Stata to predict the value for that coefficient, not the coefficient itself. So here are population size, unmatched and matched. We went through this before. So here are the results for our CP and or spina bifida, those with pediatric onset, basically. As you can see in our unmatched group, ages for cases are they're slightly younger from our control group, and there are more females than males, which was fixed when we had our matched group. There's no difference. And again, as you can see, between unmatched and matched cohorts, look at the rate of these chronic conditions. Like if you look at here, cases have substantially higher Elixhauser comorbidity, any psychological, any cardio, any musculoskeletal conditions, which was expected. We knew that from our previous work. These are the crude rate of top PQI among people with CP or spina bifida. Among the top ones, COPD, pneumonia, which is a bacterial pneumonia, UTI, are among the highest. And as you can see, there's a huge gap between cases and control. And these are the end results. These are the adjusted odds ratio for any PPH, the composite measure, and the specific PQIs. As you can see, the risk for any PQIs is 4 times higher among patients with CP or spina bifida. Again, the high ones, pneumonia or bacterial pneumonia is 3 times higher. UTI is about 6 times higher. And this is the first view for the use of preventative services. We interacted, for instance, we look at the specific preventative services, and we interacted that with our exposure variable, which was the disability group. As you can see, for instance, conducting cholesterol screening every year would decrease the risk. We compare the cases, people with CP or spina bifida who has done cholesterol screening with cases that did not do the cholesterol screening. So the screening itself decreased the risk for PPH. Bone density also decreased it, but it didn't come out significant because it crossed the line. Annual wellness visit definitely increased it for everybody and among our cases. I do want to mention, because that's a repeated theme, As you can see, diabetes and PTOT increasing the risk. And the reason needs to be explained. It's not like these screening tools are health promoting services, I would call it, bad for increase your risk. It's because based on current United States preventative guidelines, not everybody is eligible to be screened for diabetes. Usually they do that for overweight or obese people. So these are people who are already at risk. And PTOT is expensive. They don't call it, they don't consider it as health promoting services, although literature has been shown among people with disability, this is something that can help them to basically increase their functionality, or at least keep it at the same level. So that's why these two, and you would see that this is a repeated theme. Adults with traumatic spinal cord injury, almost the same thing. I'm not going through these numbers because they repeat themselves, the same theme. As you can see, again, the crude rates for top PQIs, substantial gap between cases and controls were presented in this pinkish peachy color. Again, top PQIs, as you can see, urinary tract infection, pneumonia, heart failure, and COPD among this group. And these are odds ratios. Again, any PQI, I will pick on the top ones. For instance, hypertension, people with traumatic spinal cord injury, almost 4 times at higher risk to get hospitalized for hypertension, for urinary tract infection, and for diabetes long-term complications. Again, this is the basically influence of use of preventative, I would call it preventative services or health promoting services. As you can see, cholesterol screening decreased the risk for everybody and people with traumatic spinal cord injury. Bone density is in the right place, but didn't come out significant. Annual wellness visit among the 3 groups for everyone and for people with disability came out significant. And the same, again, theme for diabetes screening and PTOT. MS people are, again, very similar, though they are not, the difference, the gap is much smaller compared with other 2 groups, maybe because the disability is not as pronounced as for people with TSCI or CP or Spina Bifida. But it still exists. Any PQI marginally significant is about 1.5 times higher among people with MS. Urinary tract infection definitely about 4.9 times higher among this patient cohort, and bacterial pneumonia also came out significant among people with MS. And again, this is the effect of use of preventative services among this population. Cholesterol screening, bone density, again, didn't came out significant, but annual wellness visit came out significant for everyone and for those with MS compared with MS people who didn't go for their annual visit. So this is basically the summary. As we can see, in all 3 cases, though for MS people, it was marginally significant, but having this set of disabilities increased the odds of potentially preventable hospitalization. Conclusion number 2, use of preventative services, especially annual wellness visit, decrease the risk for PPH substantially. It basically cut it to half for all 3 groups, compared with those with disability that didn't go for their annual visit. So to conclude, basically, among all PQIs, urinary tract infection and pneumonia were the common PQIs that were people with disability in either of these 3 groups have higher risk to get admitted to hospitals for. So what should we do about it? And I'll go through limitation before, let me just stay right here. What can we do about it? I want you to think that this is not just a study to show that it was higher. Probably we would guess that because these people have more complex needs. What I didn't show here due to time limitation is the cost factor. Cost of hospitalization is 10 to 15-fold higher, even if it's just for one night for PPH compared to an office visit. These conditions can be really addressed through office visits. So the conclusion is, how can we increase and enable office visit or access to care for these patient cohorts, which is more efficient, and to reduce PPH among them. And I will talk about it at the end. This is one of the projects that we conducting through RRTC. We change our medical procedure based on these findings to see the effect in Michigan medicine, actually, to see how we can address these adverse health events among this patient cohort. So our study were obviously, studies were not without limitations, lack of variables indicative of timely access to healthcare, like the density of primary care physicians in the area is an important one. Rigorous socioeconomic variables were lacking. These are basically limitations of claims data we are dealing with here. We also didn't have functionality index to determine the severity of the conditions. Obviously, you notice the wide confidence intervals. It goes to the fact that not everyone with TSCI or MS or CP are basically the same. It's a heterogeneous group of people, individuals. What else? The results are not representative of the United States. We use data from privately insured people with stable enrollment, which tells you about stability of income and probably higher education. So probably we are dealing with some potential selection bias that we cannot do anything about. To address those, actually, we are using Medicare claims data, which is publicly for publicly insured individuals, and we hope we can address some of these limitations through that study. Policy implications. Although not all potentially preventable hospitalization are avoidable, we are completely aware of that. Our results indicate that use of preventative service is associated with reducing risk of PPH. So the point here, how can we incentivize providers and patients to use these preventative services more often? Improve clinical accessibility to adults' health centers. This is something that we noticed for adults with CP or spina bifida. When they basically cross the line from childhood, they enter into this fragmented healthcare system, and it's hard to make an appointment and basically have access to care when needed. These are the things that needs to basically, the outcome should be the outcome of these set of studies. I mentioned that we are using Medicare claims data right now to conduct the same set of analysis, basically comparing people with private insurance versus public insurance. This is ongoing. And with that, I am done. I think I'm a bit over time. So these are pictures. I will make it quick. These are pictures from Ann Arbor. I hope at some point we can start having face-to-face meetings. I have two announcements before we start QA. October 14, we have another presentation by Dan Whitney and Dr. Hurwitz. And there's another one in January 13 about the importance of broadband for individuals with disability with Dr. Clark and Rontal. With that said, I am done.
Thank you very much, Alham. We really enjoyed your presentation, and there are several questions already in the Q&A. Before I start posing some of those questions to you, I just want to remind people to type any questions that you have in the Q&A box that's at the bottom of your Zoom window. And if you need to use your audio, please click on the hand icon also at the bottom of the Zoom window to raise the hand tool and let us know you'd like to speak. One of us will unmute you and prompt you to speak. So with that, I just wanted to start with a question from Yochai Eisenberg. Elham, can you talk about how the conditions were chosen that were part of your study?
That's a great question. For this specific project, when we were writing the proposal, we were looking at permanent or chronic disabilities, and we thought it would be inclusive to include both pediatrics, people who basically from the get-go, from the beginning, were dealt with these disabilities, such as people with cerebral palsy, and then acquired condition such as MS and TSCI. There are two different conditions. MS is obviously developed. It's a condition that developed for some people, and TSCI is totally based on accident. So there, as you can see, there's diversity and homogeneity among these conditions, and we thought they are kind of represent conditions that we wanted to conduct this study. The second reason was we had the diagnosis code. We knew we were using claims data, and it's easy to define this cohort of people instead of just using functionality as a disability that we used previously using survey data.
Thank you, Elham. Another question from Yochai. She would like a little more information about the interpretation of the control group. How would people with other conditions that may be disabling, how were they handled with the control group? And examples she gave were stroke, Parkinson's, arthritis, amputation, etc.
That's a great question. And actually, that's a question that was raised by the reviewers when we were sending the manuscript for publication. For this set of studies, we decided to have our control group people with either of these basically non-neurologically complex conditions. So we excluded people with MS, spinal cord, and CP or Spina Bifida from our control group, but we did not remove the other conditions, like we didn't look at Parkinson or Alzheimer's for this specific study. They kind of represent basically population norm that did not have this specific set of disabilities, if you will.
Thank you. I'm going to move to a question related to the data. When you examined cost data, did you include physician fees in your data? Physician fees would be part of the professional claims.
Great question. We did not analyze cost data because when we were writing the manuscript, it was too much. We did analyze the cost data, and the way we measured it, we compared office visit, average office visit, any type of office visit, compared it with average cost for potentially preventable hospitalizations. That data is available. We didn't put it in the manuscript, and I didn't present it here, but what I mentioned was based on that. To answer your question, yes, cost for physician is included, is part of the cost. So when you measure the cost, is the facility cost, physician cost, lab orders cost, all of them combined together to measure the average cost of office visit or hospitalization.
Yeah, another question related to the claims data. This also from Yochai. Are there any factors within the claims data or data that can be linked to such data that could account for barriers or facilitators to preventive health visits? Or could there be an interaction with the use of preventive health visits?
Yes and no. Unfortunately, with Optum, where our hands were limited, we could not merge it. We used the SCS view, and we could not merge it with any other data set. If you use Medicare claims data for this type of analysis, again, the answer is yes and no. We've done similar study, which is published in Annals of Family Medicine among everyone 65 and older for potentially preventable hospitalization. In that case, we merged the data with area resource file, which gives you the density of primary care physicians and hospitals in the area, and census data, 2010 census data that gives you some SES variables. But if you're looking for, there are some ways to measure if you have the zip code address, the time, others have used that. I haven't used it myself, but you can estimate the time to closest physician's office in your data using Medicare claims data. But with Optum, you don't have that option. I'm sorry, just to add to that, there are studies who have done this similar work and found out that risk of potentially preventable hospitalization if the physician's distance is more than 30 minutes increase. So accessibility is definitely an issue that we couldn't address in our analysis. Yes.
Thank you. We have another question that's looking for a definition. Can you define the term that you used, and that term is functionality?
Again, that's a great question, depending on what condition you're talking about. Using claims data, that was one of the limitations. For definition, I am not the best person to address this question. I provide an example to say why. For instance, we used, Dr. Mead and I conducted a study using medical expenditure panel survey. Within that data set, there are variables that ask if you can perform certain things like ADL, IADL, walking up the stairs, walking certain distance without help. And we combine all these variables and measures to come up with the definition of disparity or functionality, functional disability, basically, based on those measures. Claims data, we did not have any of those. We are basically limited to ICD codes to define functionality. Just to add to that, if you're interested, there are people who have used frailty index. It's not exactly the same as functionality, but that's something that can be used as proxy using claims data.
Thank you. One other question related to the characteristics of the population from Lisa Raver is, what was the racial, ethnic, and socioeconomic breakdown of the cohort?
Great question. Again, due to time limitation, I didn't have time to report those data. In our regression analysis, we did have racial ethnic disparity data and some socioeconomic variables. And among everybody, not just people with disability, risk of PPH was much higher among African Americans, those with lower income and education. None of it is surprising because there's literature behind that. To answer your question, the distribution of race and ethnicity were almost similar to what we see nationwide. And we had the control for being African American, Hispanics, whites, Asian, where also we had enough sample to include those, and those with missing or other race and ethnicity, we combined them into one group.
There's also a question asking about what research shows about patient preferences. This is from Ernie King. Do patients prefer to have more office visits? And how does that relate to the risk of preventable hospital stays?
This is an absolutely great question. I think only a mixed method analysis, combination of quantitative and qualitative analysis would answer that question. Great question. I don't know the answer to that, but it would be very interesting to study that. Just to mention, these are people with disabilities. I know for fact from personal experience, going to hospital is a shock to the system for many of these patients. It's hard. I'm assuming, and I might be wrong, that hospitalization is probably hard for these people, so they may prefer office visit. But to answer this question based on evidence, we need to do some qualitative analysis. Patient preferences, we cannot find them in any secondary data, not claims data, not survey data, unfortunately.
Thank you so much, Alham, and all those who posed questions in the Q&A session. We are at the end of our webinar, and I do know that if you have follow-up questions, Alham and others would be happy to answer them and follow up with you outside of this webinar. And thank you again.
Thank you all.